Hello everyone, thank you for joining. I think we're going to begin now, so I'm very happy to welcome everyone to our third webinar for the Curve, Strength of Evidence, with Vish Viswanath presenting. My name is Lydia from M&C Saatchi, and we will be coordinating this webinar. Vish Viswanath is a Lee Kumke Professor of Health Communication in the Department of Social and Behavioral Sciences at the Harvard T.H. Chan School of Public Health. Dr. Viswanath's work focuses on translational communication science to influence public health policy and practice. We had a great conversation on strength of evidence at our last summit. This presentation includes some of this updated thinking. And a couple of points for housekeeping. We are recording this webinar, so please keep your microphone muted. We will try to keep all questions to the end, and please use the chat function on GoToMeeting to send through your questions, and we can take them one by one. To avoid communication, to avoid confusion, just please keep it in the chat box. And without further ado, over to Vish. Thank you.
Great. Thank you, Lydia. Appreciate it. Good morning, good afternoon, good evening, depending upon which part of the world you are in. So thank you all for joining at this time. So the idea today is really to sensitize you to the notion of how evidence or what evidence is and how it is collected and why is it useful as we discuss responsive feedback mechanism approach to interventions. What I want to do is to start with a definition of what we mean by responsive feedback mechanisms or RFMs, and try to identify some of the features. In a sense, what we mean by RFM is that it is a process or a methodology to test a number of ideas of interventions, ideas that can be turned around quite quickly, fail early, and find successes worth further exploration. These are deliberate testing cycles that provide an opportunity to test and tweak potential adjustments to programs based on performance or shifts in context. When situations or or conditions change, and a RFM approach allows you to make that quick pivot, so to speak. Through this philosophy, the critical point is that through this philosophy or approach, programs embrace agility. So we can identify interventions that are performing as expected, or if they're not performing, why they're not performing, and how do we improve them. So in practice, it is based on observation, experimentation, adaptive learning, that is, you're changing the learning as the situation changes, and improvement to quickly identify the factors that may increase the program success, and where possible, to implement those changes. So in practice, it relies upon frequent analysis of data, including both process and outcome measures, and to identify those areas for iterative improvement while the program is still active in the field. So this is a significant departure from a more orthodox approach where you do the baseline and maybe some process and then the end line or end of the intervention approaches, evaluation, at which point it becomes a little too late to make the adjustments. The question often comes up, where do RFMs fit within the larger ecosystem of research and research evidence? So on the one hand, our gold standard or at least the perceived gold standard is randomized controlled trials, which have tremendous advantage. I'm not against them. Randomized controlled trials have tremendous, very high internal validity, and we can confidently attribute any changes in the outcomes to the intervention itself. So that the causal attribution can be done with a great deal of confidence. Plus, we have a great deal of control over the intervention conditions or the research setting, so to speak, including the stimulus, including what audiences are exposed to. But that is one approach. On the other hand, in an RFM type approach, we are really aiming for high external validity. Because the conditions under which we do our interventions often change. The situations, the so-called real life situations intervene. We have much less control over what people are exposed to, what people do, and that creates some challenges. Plus, we are intervening in very diverse populations and contexts. So that's where I think RFM approach or methodology provides a distinct advantage over RCTs, though the RCTs can be included. So the question often comes up, how do we prioritize, use and interpret data to make the kind of changes we want to make in an RFM approach? There are three things that I will try to cover as we move forward. Number one, I think the question is on how do we place data in context, in the context of the intervention world. And this constant tension, how do we balance rigor, which is what we discussed in terms of evaluation and data collection, but with agility, our ability to pivot quickly as situations change. And then how do then we make those informed decisions? So let me talk about placing data in context. So here, while many published studies, perceive, feedback from community members or participants as data to inform future interventions, RFMs are a little bit more formalized mechanisms in which data are systematically collected, either from planned experimentation or intervention. Sometimes, that's one source of data. The other could be unstructured data that arise naturally from the program. Or we might have pre-existing program components that generate observations. And also critical, I think this is an important point to emphasize. We really want to take into consideration the implementer and practitioner input as we do this process, because the implementers provide very rich input in terms of they're a great source of learning. We can actually privilege local preferences and priorities when we take that feedback from the implementers, as well as we'll have a better idea on the ground view of available resources. And again, lastly, the key feedback of intervention program progress can be gleaned from from implementers. So it's not just one thing, so there are different sources of feedback, all the way from highly structured experimental approaches, including sometimes inbuilt RCTs, to more unstructured, real-world contextual data. So, for example, if you take, Dimagi, which has run some interesting experiments where they looked at both interim and outcome measures. What they have done is they have developed a chat bot that can give information to new mothers on health nutrition and hygiene related topics. So it's interesting the way they approached this. They started with a phase where they had initially 10 users and they developed this kind of a piloted their chatbot with 10 users, and then they will go up to 100 users to determine how successful are the sort of the interim factors informing engagement with the chatbot. And that will inform how many queries are handled by the system they are designing versus the need to be sent to a nurse for further review. So the chatbot will answer most of these questions, but if necessary, they have a live help in terms of a nurse for further review. They will also be able to find out what modules have the highest user engagement and how high and low engagement users perceive the system. So, and then these initial data will be used to inform their next phase towards this ultimate outcome of increased maternal nutritional knowledge and behaviors. So they started with 10 12 people, and they're experimenting, then they're going to 100, and eventually they will scale up to 1,000 people. So that's a nice way of looking at what the interim factors are and how those intermediate factors are related to the outcomes. Another example is MTV Sugar, where again, the goal is eventually, you want more young adults having positive conversations about family planning and using family planning services. That's the ultimate goal. But before that ultimate goal, you want to think about what are the outcomes that will lead you to that goal. And here are some indicators of those outcomes, such as changing in behaviors, in norms, and increased knowledge about health. But I think before you go into those outcomes, you really want to look at some ways of finding out if these actions you're taking and the intervention are leading you to those outcomes or not. So the program started collecting data from formative research, and those data were used to select RFM activities and form some hypotheses towards the outcomes, key areas and trends. I should stop for a minute and say that what is critical here is to have a theory of change. How do you see this could be kind of a working set of hypotheses that will guide your work. So the ultimate goal is changing social norms and conversations around family planning and behavior around that. How do you get there? You have a set of hypotheses or a theory of change, and that will let you start looking at what are the mechanisms that you want to tinker with or intervene on to ultimately reach there. So, and data can be incorporated at each of the RFM phase. So for example, in the MTV Sugar case, one is to look at the number of, starting off with the number of people who have seen the videos. This is a very broad set of indicators such as reach. It's very large, it's relevant, and it will tell you on what the audience are seeing. But I think based on that, you want to say, but in a case like this, it's very difficult to change the program. It's very expensive to do that. The other approach is to say, okay, having seen now that it has reached a large number of people, but not all of them will be responsive. So you sort of begin with a funnel approach where you're honing in your audiences, looking at who is more engaged. and the and so you can look at social media data to see measure some indicators or some of markers of engagement, such as likes or comments people make or shares. Shares are sort of an indicator of a conversation people may be having, and expression of sentiment. And then you can also look at ultimately the action people are taking in terms of measuring the uptake on services. Again, so these are kind of a different data are being used at different stages of RFM. The take home from this is that that it's not just one piece of datum or one type of datum, but you can be very flexible depending upon where you are in a given RFM phase. I next want to discuss the tension one conventionally feels between balancing rigor and agility. The reason this is important is generally when we talk about research and evidence, we sort of communicate or imply that we are looking at the strongest evidence possible, and that is true in general. If you are trying out a very new drug, then you want to do some very systematic review of RCTs, or you want to conduct randomized clinical trials. And there are different varieties of, there is some sort of a hierarchy that the Centers for Disease Control and Prevention in the US talks about, where you get this kind of a very strong evidence from randomized controlled trials, or in most cases we have also, we also do quasi-experimental designs in the field, and sometimes we have observational studies. There are conditions under which we are not necessarily looking for that level of rigor, because we want to be very agile. We want to see how the real world conditions are influencing our implementation context, in which case, this is where implementers and program personnel become their input becomes very important. We might collect sometimes anecdotes, we might collect impressions, or do quick type of surveys, such as windshield surveys, to get the information that is needed. Again, the goal here is a constant challenge between balancing agility with accumulation of evidence, but what RFMs do is to allow you to provide that flexibility depending upon which phase you are or where you are. And this kind of approach, RFM approach, also allows you for using multiple designs. It's just not to collect the data. It's just not one design. Depending upon where you are, your resources, your conditions, you may be able to use different things. And as a program, as you just saw in the MTV example, as the programs evolve and the implementation context changes, your priorities for data collection may also shift. And so you need to really look at data from these different methods and integrate them in the context of the so-called real-world evidence. I'll come back to this issue of real-world evidence at the end of this presentation, because even someone like Food and Drug Administration recently in the US has been paying a lot of attention to this so-called real-world evidence. The last section I want to talk about is, so how do you make these decisions? How do you make good decisions based on this? And some questions often come up when we discuss this. The question is, when are our RFM data good enough to prompt action, right? So this is Now, we often talk about, sometimes we say, typically in a research publication, in a refereed journal, you end that conclusion in an article always says, oh, more research needs to be done. But if you're really in an implementation context, we don't have that luxury of more research needs to be done. You just need to know at what point, we can say, we have enough to say we will make the necessary changes. Also, I think in the context of interventions, we want to know when can we drop it. When can we say the idea we have is not working, we should go to another idea. Again, that's where RFM can help you. The question again, as a related point is, how long should we monitor intervention data before we determine if we need to switch gears, so to speak? So we can't afford to do the typical RCT and say wait for 3 years, 5 years, 6 years. That's not the luxury we have in intervention world. So we need to really maybe do it in a more expeditious way to make those changes, or even drop the interventions. And again, it also it depends upon where you are in the cycle of the intervention. So what RFMs do is they offer this opportunity to test a number of these ideas very quickly. And if you have to fail early rather than later, and find successes that are worth for further exploration. So here is an example of the kind of approach one can take at different stages of RFM. These are sort of illustrative, not exhaustive list. So before you even start your cycle of RFM, you can generate some hypotheses and activities that are supported by prior research, or we all do formative research. We can use that. We can also use appropriate study designs at that stage. And you might want to structure your data collection activities for the cycle at this stage that can provide that context for any observed change. But once you begin the intervention, then that's where your data will determine if insights from inform the future actions or capture your hypotheses for future testing. This is also a place where you can generate some ideas for iteration based on real-time observations. I want to emphasize the word iteration. So this notion is that in an RFM approach, it allows you to iterate or change as opposed to say an RCT or a long-standing trial where the intervention itself doesn't change. The entire process of adaptive learning is the idea is to allow you to change, and of course it might also let you make a decision on if you want to shift the timeline if things are not working out the way they should work. And of course, after the cycle, you might want to weigh your evidence in the context of the program. You can discuss with stakeholders their expectations and to determine if and how your hypotheses, from the theory of change were supported. You might be able to make a decision on how do you refine or refocus your activities for the next cycle. And as you saw in the example of Jimagi, those findings can inform scaling up of the project. So within these decisions, the weight given to different forms of evidence may shift over time. And while contextual evidence or evidence gained from practitioners may inform decisions at the early stages or early steps, then there may be more of an emphasis on more rigorously collected data as the program prepares to scale up. In the Dimagi example, they started when they first started, the 10 people, most of the data were qualitative based on observations with people. They became slightly quantitative as chatbots were being tested out along with a nurse with 100 people. And when they go to the scale of 1,000 people, then they can systematize that data collection and make it much more quantitative. So, so there are a number of considerations that you need to balance to take the kind of action when you do this RFM, and you need different qualifications for how much evidence is enough to justify change. You have, where is the program? What is the life cycle? What are the risks and costs, effort to test? What are the benefits? The cost benefit analysis is very critical. Sometimes it is very formalized. As in the case of a drug trial, it is much less formalized in this RFM cycles of rapid testing and more and pivoting, and how quickly you need to take action. As I said, because you can't always wait for everything to come in. For example, in the MTV sugar case, based on the life cycle of the program, it was determined that using social media components of MTV sugar would be a potential for high impact and lower cost actions. So the first phase of the project demonstrated that this could have a high reach among the target audience, and then additional metrics were determined, showed that the ad with the highest engagement. So they took that ad, as you see here, with the highest engagement, and that was used to refine the messages for the next phase. And engagement, as you see on the slide, was tracked through number of clicks, number of reactions in terms of likes, the number of comments people and the number of shares. So this is one way which will very quickly provide you with the kind of data you want and show how your future work can be informed. And then what RFM approach has allowed in this program is also to do some quick thinking and quick changes. For example, when this ad came out, within the ad, Facebook's algorithm designated that this honey and banana website as too explicit. And so that led to the issues of optimizing content and for people to access the link and click to from Facebook. So the program decided to another plan, so where linking this Facebook to MTV Sugar website, and from there to the Honey and Banana website. Now that is the kind of adjustment that was possible when they quickly started tracking these data, in a cycle like this. So the question that one asks is, are these steps feasible? Do they make sense? Are they impactful? And are they testable? So these are the kind of matrices you can use. For example, one insight that was developed based on this, these kinds of RFM cycles, was that messaging around long-acting contraception was the most engaging, as you saw in the previous ad. So that allowed, an idea for what could be changed. So featuring a storyline that demonstrates characters who use an IUD, and you can understand, based on that, the feasibility is very high. The impact seemed to be high based on the engagements, and it is testable. So these kinds of insights from the MTV Sugar test case demonstrate that certain characters or storylines drive or drove most engagement, So that will allow the program to focus in the next phase on those characters. And also, we found that asking for personal stories did not result in relevant comments. So that changed to providing general advice and talk about contraceptions. So these are some of the things that could be done again using this kind of an approach. Let me end here in the next minute or so and open up for questions. So the idea is RFM approach is in this case, when you use an RFM approach, evidence is drawn from diverse sources and study designs. So that kind of eclecticism is very important here. So it's just not RCTs. Making informed decisions on RFM cycles relies on considering data quality as well as the programming context. And the priorities of the data collection and the kind of data you want to use and the levels of rigor that are needed may shift over time depending upon where the program is. So I want to end here. As you heard me talk, I think it's useful to know. And think about, in your own context, how you have determined the best sources of evidence to use, say within your own organizations to guide program decisions, and how, collection of data, interpreting and acting upon it played a role in that process of program decisions. One of the questions we get asked about barriers to agility. Have you encountered within your organizations? We all have faced this as we do our own interventions. And the question then is, you have very rich learnings within your own experience in terms of the strategies you might have used to address these barriers. So let me stop here and open up for a conversation and discussion. Thank you.
Thank you so much, Vish. That was really fascinating and very succinct. Just while we wait for people to share their questions, and if you please use the chat function so we can moderate them, which is within GoToMeeting. I just wanted to talk a little bit more, ask you a bit more about this word evidence, which, you hear the word evidence and it connotes something that's potentially very rigorous, very demanding, with kind of high standards for reaching it and then acting on it. But I just wanted to ask a little bit more about what do we mean when we say evidence in this context?
Yeah, thank you, Tom. Some of people like me who were were steeped in the world of randomized controlled trials, sometimes have this, or brought up so-called, I would say quote unquote, brought up in this notion of whatever data you gather from highly rigorous trials, either randomized controlled trials or field or quasi-experimental designs. And that implies that evidence is knowledge you glean from extremely rigorous, strictly conducted trials where you have exercised greatest degree of control over the stimulus, I'd say a drug, and that you have a control group that is not exposed. So a group which is similar to the experimental group, which did not get the drug, right? And I think my feeling is based on experience, and I'm sure people on the webinar can have equally rich experience. We are not in a court of law, where we are making these arguments. What we have here is really how do we get to those outcomes, and what will help us make some decisions that will allow us to get to those outcomes by tinkering, by changing our interventions. And that means, doing it very quickly, as has been observed, does the information we have today allow us to do those decisions better than what we had in the past? So in fact, I was reading that even FDA, Food and Drug Administration, recently made a major decision. I don't know how much attention this has received. Usually, Food and Drug Administration makes the decisions based on randomized controlled trials, whether a drug is introduced into the market or not, and then the drug is tracked and monitored, the impact of the drug for adverse events. Recently, one particular drug that was used for one cancer was actually approved for use for another cancer. And that was not necessarily based on a randomized controlled trial, but what FDA has concluded as a real world evidence, And what they did was to really look at a number of other sources of data. In this case, electronic health records, physicians, oncologists' input, and other kinds of experiences. So in essence, what I'm trying to suggest is it's really information that you can glean based on some kind of more systematic, thoughtful observation. And the rigor with which you draw on these observations varies where the program is. So the evidence has, the understanding of what we mean by evidence has to be a little bit more flexible than what it might connote in a typical drug trial. So.
Thank you. That was a really interesting answer. Just waiting for anyone to add a question in the chat box, or do email the curve at mcsaatchi.com if the chat box doesn't appear to be working for you. Vish, I also wanted to ask about, how any strategies or any ways you've heard for people to align stakeholders. I guess at the outset probably makes most sense. In terms of what what internal benchmark you choose, or what how you can agree with people to begin with. What strength of evidence do we need to apply to make a change in our program? Do you have any sort of general advice on that?
Yeah, that's an interesting question. I would love to hear from other people on the call. When we were writing this piece on RFM with Dr. Sohail Aga, and we were having these discussions. And one thing, one insight as we had these discussions, we learned, traditionally, you have, these separate functions, right, of MLE who are sitting separately from implementers, and so those are two different functions in an organization. So the evaluators will have very little to do with the implementers. So if I'm an evaluator, I go in, I sort of evaluate the program and then make a final report. And often I see that that's the reason evaluators are often thought of as auditors rather than people who are helpful to the program, Whereas I think in an RFM approach, you need those functions to be much more critically integrated. And so your evaluation then and data collection and designing means for data collection require really a solid stakeholder input. That's where it has to be much more, this is my personal view at least, it has to be much more participatory. That is, you have to really engage people right from the beginning, different stakeholders, and what is it, their expectations. You have stakeholders such as funders who have one set of views. You have leaders in an organizations who are straddling the kind of honest brokers between implementation and the funders. You have the implementers who are executing the program day in and day out. So you really need, and of course you have the clients, who are ultimately our audience, target audience. So I think it has to be much more participatory, where you do want to bring in these different stakeholders in generating the designs, getting that buy-in and involvement right at the beginning, and doing your data collection. My feeling and experience is that if you are participatory and engage those stakeholders, number one, you are likely to collect data that are much more useful. Number two, they are much more likely to have a buy-in and investment in the data collection process. Number three, they are much more likely to participate and use the data to implement it.
Brilliant. In terms of, I know you're asking about how you have examples where we have in our work done this, and you obviously touched on that MTV Sugar example, and I was also really interested in the balancing considerations for prompt action. Where are you in the lifestyle for the program, what risk, cost and effort is there to test. And I guess one of the things with that is we were just looking for additional insight to help us make a better decision about how we engage people, and there was really very little downside for that as well. And so I guess that was a good example where we were just looking for additional data, and social media is an excellent source of that, and we're able off the back of that to hopefully just inform our activities and provide the most relevant content to increase engagement at every stage. And I think that really resonated as a sort of key consideration. Sometimes it just helps you make a slightly better decision using that data than you might have otherwise made. And in that instance, I guess strength of evidence is an easy consideration because it is just a bit more than you knew before. But of course, there are other examples where it can be have greater risk or cost or effort to test it. I'd love to hear from anyone on the call about instances where they have faced that problem and have found a strategy to overcome it. We do have one question here from Oren at BRAC. Vish, you had mentioned that a good data source can be the natural or unstructured data arising from an intervention. Could you give an example of that? How do you know which natural data is important, and how can you collect that data when you have previous plans to collect it?
Sure. So let me think of a couple of examples, and I would love to also hear from other people, on the webinar. One of the examples I can give you is, we were engaged in a huge cardiovascular disease program, which is kind of a huge, field experiment that involved a large number of people, communities, and organizations. What we were looking at when we were looking at the data, we had two observations that we found that we were not able to explain. One was that there were not enough people coming into the clinic, even though that was our goal. So there was not enough uptake of the behavior. And so we were wondering what the heck was happening, because I think the data we were collecting were not showing the why, or the reasons people were not coming in. That's when we began, when we started noticing some observations from people in the field, our health educators who were saying, in the control group, we have, the people are not hearing the message, or every time we go and talk to people, they don't seem to have heard it for whatever reason. And then what we learned is that the channels through which we were communicating were not the channels through which people were getting that information. And this was based on our implementers, unstructured conversations we had with our implementers, which allowed us to go back and say, let us look at it more systematically. What is wrong with the channels we were communicating, through which we were communicating. And so that kind of a qualitative, unstructured conversations and input from the field staff allowed us to go back and look at the data we already had, go back and do some secondary analysis and change our intervention plan. And I should also say that the plan was very simple. It was not very expensive program or television program. It was basically, we decided we will use some postcards to overcome the challenge of the other platforms we have used, and the result is successfully we were able to increase the bump in the number of people who came to the clinic for screening. So that's one example of how even conversations, experiences, and observations of the field staff could help you go back and take a second look at the data you had.
Great. Another question here from Amika Okafor. The challenge sometimes is knowing when the evidence is enough to convince the stakeholders that there's a need to make a change within the project cycle. Sometimes the question is, are you sure the change is not a hasty one? And are you sure that the new idea will work better? Or will there be a new adjustment not lead to additional, or will the new adjustment not lead to additional costs not originally budgeted for?
I think that's an excellent question, and that is the kind of question RFM is supposed to address, I think. Where RFM will help you is if you discover that the approach you have doesn't work, let me put it that way, then when do you want to discover it, right? And that discovery, you would rather do that early into the cycle, into the program, rather than later into the program. And certainly, as you change from plan A to plan B, then the question, as you're rightly asking, is how do you know plan B is better? We don't, but there are two ways of, or two criteria or ways of making that decision, I think, So one is you already start with some kind of a working hypothesis or theories of change. And that might allow you to say, okay, so there is a reason this plan A did not work. We can try and pivot to plan B based on this theory of change we have. That's one way to think about it. And second, again, you don't always know what works, but at least in an RFM approach, you will know it sooner than later that your plan B may also not work and that you might have to resort to plan C. And I completely agree with you that sometimes it could be very costly, but the whole idea is to avoid that cost and discover it at the end rather than at the, early in the process, I think, and this is where I think it's very critical your theory of change will help you, are you meeting those intermediate outcomes leading to your ultimate outcomes or not?
Brilliant. And we got a question from Amar Norkar at Tata Trust. So he says, we conduct training workshops hoping that the behaviour of doctors will change in prescription practices. That was not enough. We broke the process and collected information in the following lines. Do they understand that they can start NCD, DM, management? Is there any adequate protocols in place, inputs provided, and if they will be able to change to physicians capable of handling NCDs? This helped to an extent. The clinical audit was facilitated by a local medical college. That sounds really interesting, Amar. I think I'd love to discuss that a bit further. And Vish, unless you have any initial comments, if you're on the line and want to sort of speak to talk a little bit more about your experience there, that would be certainly very interesting.
Yeah, that's very interesting because they are doing this in the context of a health system with providers. And that's a very nice insight.
Hi, this is Amar. Am I audible to you?
Yes, hello, Amar.
Hi. So, we assume that mere training will help, and immediately after the training, the behavior change will be seen. That didn't happen, and since I'm part of this consortium, closely following work of Vish as well. So we said let's break down this process, and we used some forms, we structured some questions and went back to the physicians asking them, what is keeping you from changing from a normal physicians to physicians who can handle non-communicable diseases? Because in Indian context, management of diabetes or hypertension at PHC is not everybody's task. They think it is a specialist's work and the patient should be referred to higher centers. This is a recent phenomenon, and this was not a question, this was just a sharing with you guys that it helps to capture unstructured information. We could have not found that, breaking your steps, framing right questions, asking them on right time helps. Since we asked them in the beginning and we went and visited them, we were able to make some policy changes. In the first instance, we found that there were issues with the supply of drugs. So we could go back to the administration stating that we need to do the policy changes, include the drugs that are required and oversee their supply. So somewhere in a complicated project, this type of approach of the one that we are discussing is really helpful.
Brilliant. Thank you very much for sharing that, Amar. And I think we'd love to follow up with you as well, because that sounds like a really interesting case, and we can certainly learn from that and sort of capture those learnings and share them with the group in in part of the work that we're doing going forward, capturing practical cases where responsive feedback was used to improve program outcomes. That's really helpful. Thank you. So conscious that people are going to be needing to leave for their next meetings or to enjoy their evenings in a moment. So do let us know if there's any other questions for Professor Viswanath. If there's not...
Thank you, Tom. And I think it would be nice to also hear about people's experiences and the challenges they have in collecting the so-called evidence or data and how they managed both, we heard one good example now, how they managed to, overcome those challenges and make the kind of changes they made.
And I think, sometimes it can just be picking the right indicators, and that's something certainly we learn from the commercial sector as well. You can gather an awful lot of data across a number of metrics, and it's really deciding from the outset which ones you're going to listen to. Again, I just point as an example, just because you've explained it quite thoroughly, Vish, is that for MTV Sugar, at the different stages we chose different metrics that were relevant to help us make the decision that we wanted to make. So are we reaching people and are they receiving our message? Obviously video views was pre-agreed as what we were going to base our next decision on. And equally, when we were trying to engage, it wasn't so much how many people we'd reached at that stage, but what elements of the social media advert were they engaging with? For example, we used a carousel with a number of different images, and we worked out which of those images was getting the most clicks. And before we ran that test, had obviously said that's going to be our key metric that's going to allow us to make a decision and inform our future phase. And similarly, on that final phase that you mentioned, the action phase, we looked at, what formulation, what wording is going to drive the most number of clicks. Again, not so interested at that stage about what comments we receive, more about what drives best action towards the online services that we were offering via Honey and Banana. So again, choosing an indicator that is most appropriate for the decision that you're going to need to make, and focusing on that when you're gathering the data and reviewing and analysing the data, so that you know from the outset what decision you want to make and how that data is going to help you to make that decision. So I guess I just want to sort of build on that as well, because that strikes me as just an important thing to help you choose what data you're going to be collecting and analysing, to help you make quicker decisions as well as better decisions.
Thank you, Tom. Absolutely, I agree with you. It depends on what your theory of change is and what indicators are appropriate for each stage of that, and to see to what extent those indicators are informing your both intermediate and ultimate outcomes. MTV Sugar is an excellent example in many ways, because you have the right target audience. These are youth. They are much more savvy with new technologies and on social media. So you have a major network with a program, and then you have a component of social media. And that's an excellent illustration as you described it. But also, I don't want to leave with an impression, because I also saw a comment here that you always need to have that RFMs can be used only in the context of technology or high, such as mobile health or social media. There are one example I gave was just using postcards and changing quickly from observations in the field to changing our strategy by using postcards. So I think I want to emphasize the point, it doesn't have to be always technology driven or high technology driven. I think technology is one component, but also there are other ways of collecting this data and doing these quick pivots.
Absolutely, that's a really important point, Vish, thank you. So it doesn't appear that we have any other questions for now, but please do drop us an email if you have questions off the back of this webinar, or if there are experiences that you want to share as to how you managed some of these issues, the barriers that you faced and the strategies you used to overcome them. We'd be particularly keen to hear any of those, to follow up with you and to have a discussion offline about that, because I think that as you'll all, I'm sure, agree, the more practical cases we have, the more examples, the better we'll be able to share that with the community of practice and really share learnings about how to do this type of work, which is important but not always easy to do. So collective experience is very important. But thank you very much, and a huge thank you to Vish for sharing his time with us and his expertise. It's always a pleasure. And thank you all for taking time out of your day to attend this webinar.
Thank you, Tom. Thanks, everyone.
Thank you.